And thank you for coming. We have lots of people online. I'm hoping I think I can mute that. And if people online complain that they can't hear, then we'll know and I will demute it. But hopefully we won't hear all that beep beep. So without further ado, nobody wants me to talk about beep. So that's great that I had to say it out loud to teach clinical and non-technical skills. Her clinical practice focuses on reproductive social justice through the promotion of lactation, and I know that she'll be talking about that today. She's co-editor of an award-winning interdisciplinary lactation care text, and her fun fact, which is, I think, the most important part of the introduction, maybe I should just start with the fun fact, is that she loves to bake. Sweetbreads and muffins are did you bring anything for us? Darn! It's a personal favorite, and she's learned to do so in a more nutritionally sound way over the years. And when she's not at her computer teaching her supervisor, you'll find her in the wilderness exploring by hiking and biking. So without further ado, I would like to present Dr. Suzanne Campbell. Thanks so much.
Thank you, and thank you for those who are here in person as we have snow beginning to come down. I will warn you, I know I have about 45 minutes and I'm setting my timer, so when we hear it go off, we will know my time is up. If I don't finish beforehand, and I have probably a slide a minute, which I know you're not supposed to do, but some things I will be just introducing, giving you an idea. I am pulling through 37 years of research, clinical practice, and other components. What was not stated in my introduction initially are my disclosures, which I think it's always important to put up there for you. I've added the Lactation Education Accreditation and Approval Committee Program Site Reviewer because I've been involved with that group making the components, but I actually evaluate programs. We have one accredited LARC program at Douglas College here in the province. And the other things not stated are that I'm a La Leche League leader on reserve. I've had decades of service in WIC, which is Women, Infant, and Children, for our underserved key populations in the U.S. at both the state and national level. I have 2 adult children with whom I did get support to meet my infant feeding goals, and a 1-year-old granddaughter on Saturday who also is meeting her and her mother's infant feeding goals. So I think that those in the room will appreciate that none of this ever happens in isolation. And you see the big red arrow because I need to thank the Faculty of Applied Science and School of Nursing. My time here the past 9 years have been amazing. The colleagues, the research teams, the funding, internal, external, and other grants have just been incredible. But then you'll notice a lot of other people, some of whom I'm hoping are on the phone or video right now. Leah Geiger is our provincial coordinator, the BC Lactation Consultants Association, Tina Reve, and Jean Hagren, who's not there. We're co-presidents, but Tina's the president now. Graduate nursing students, I have Sayanthi in the room, which is exciting, and a lactation research team with colleagues from Brazil. But you cannot forget all of the mentors you've had in your life. Faculty, students, colleagues from the University of Connecticut, University of Rhode Island, Fairfield University, where I spent 13 years before I came here, and then all the physician and nursing mentors I've had over time, on top of all the colleagues and friends. Last but not least, the parents, mothers, children, families, international friends and colleagues. None of this is ever in isolation. So what are we here to talk about today? We're connecting the dots to women's health and gender issues and things that may be researched or not well because of that. I want to say flat out, the international text we created was entirely inclusive in how words were used, and I will try to refer to parents because we know that not just people who identify as women or mothers are breastfeeding. And I also want to just share some insight, whether you are a healthcare provider or not, because I know we have some students who are more lab and bench scientists, how we as a society are communicating with new parents about infant feeding decision making. And I would wager to say that infant feeding is an intimate behavior. And because of that, there are some taboos associated with it. So my objectives for today, I'm trying to figure out how to best situate myself here, are to look at the global context of lactation as health promotion, identify some best practice standards for support around respectful care, and then what are some of the key implications of the societal pressures we're seeing on new parents around infant feeding. I will consider some support measures that healthcare practitioners can use, and I will be talking with you about experiential learning and integrating the communication theory component with the hands-on learning component related to lactation. So that's a lot to cover in 45 minutes. I thought I would start with the health topics that came up as main things we don't talk about in 2020. And although none of these are related specifically to lactation, you'll see where I put parentheses, I can relate several of them to it. When we're talking about transgender women, our women, we have transgender women chest feeding. Women's pain is real. One of the #1 reasons women stop breastfeeding is because of nipple pain. Vagina, labia, and clitoris, let's add breast to the list. It's okay to talk about them. And when we're talking about women's rights as human rights, that's around work and lactation and how women are able to return. So what do these taboo comments have in common? They are all related to women's health. As I defined lactation, I see it as an intimate care behavior. They are hard to talk about, and everyone knows best. Everyone will identify the research and tell new mothers and new parents what they are to do. On our list of top 10 taboo topics for new mothers, breastfeeding versus bottle feeding is at the top of the list. I've included some of these links so you can go, but it's interesting because down there it has to do with intercourse after birth as well, as kind of a taboo topic, but something we need to talk about. And I really like the simple advice on this blog was keep an open mind, listen to other people's experiences, and as a Leche League leader, we would always say you're going to hear and see things that you never knew about before. Take what works for you and your family as you walk out the door. So I think it's important to think about that. So why am I placing lactation in a global context of health promotion and practice? So one of my other areas of teaching is related to health promotion, and I think when I decided to work with new families, that was my major motivation. I found women incredibly motivated to change bad health habits during pregnancy and motivated to maintain them. And as usually a center figure identifying what families are eating or exercise or that type of thing, it was an opportunity for health promotion. But when we look at different organized strategies, intervention programs, public health is defined as the art and science of preventing disease. So prolonging life, promoting health through organized efforts of society. We have incredibly strong cumulative evidence demonstrating that breastfeeding is one of the highest impact interventions benefiting children, women, and society. When we look at death rates of infants, when we look at chronic diseases, out over the years and other components. This Victoria 2016 Lancet series was not examining new information. It was really compiling and meta-synthesizing the data. But what I want to reinforce as well is that this isn't just up to the new parents. Parents are living in a society, and we can think at that public health level it can seem daunting, but I want to say each and every one of you is responsible for supporting new parents in their decisions, whatever they may be. Who is obliged when we're talking about support of infant feeding? And if you're not familiar in this area, the Global Strategy for Infant and Young Child Feeding came out in 2003, the Innocente Declaration in 91, which was trying to get a handle on breast milk substitute marketing globally. U.S. decided to identify it and then was one of the only ones that didn't sign it, and as an American, I can blame us for that. Many countries, American and Canadian at the moment, but there are many countries who have taken these policies, global policies, and integrated them into their national health agendas and had very good results with that. So my question is, how are we mobilizing some of this into action here in our province? And I've got two key areas, the BC Baby Friendly Network, led by the provincial coordinator, Leah Geiger, with a whole team of experts from all the health authorities around the province, and then the BC Lactation Consultants Association, of which I am a part as well. Just in case you want to know what the WHO code is, I've given a quick little link here. And remember, this is 1981 that we adopted this. And I will tell you that the breast milk substitute companies, formula companies, spend $70 billion a year on marketing. Can you imagine if even a touch of that money, 1%, was put into supporting national health programs and supporting new families in infant feeding, what a difference we could be making. I think it's about $35 per baby born annually that is spent on marketing. So if you want to get outraged about something, that's at the top of the list. What are we doing to get around that and communicate better to support parents? The WHO released this 10 steps for successful breastfeeding, and I'm blanking. 1991 is when they identified some of the components, and I think it was early 2000. But we've released new steps. What this is meant to do is to provide support to health authorities, to hospitals, clinics, community centers to support new families. And basically, it's having a protocol. It's making sure we're all providing the same language. There is lots of good evidence globally at how this has been successful. And basically, supporting birthing practices makes a difference as well. But the international consensus and declarations that I put up initially, the countries where those have been embraced and programs have been worked around them, local advocacy groups have been a huge component to this. And that's what I would call BC Baby Friendly Network. It really is a local advocacy group. I was part of a group in my state of Connecticut, and Washington State has a pretty strong coalition as well, because it's bringing not just healthcare providers, but social workers, researchers, nutritionists, immunologists around the table and connecting them with parents' voices to communities and other individuals to get a feel for how things are going. A big component is related to policy and where our dollars are being put. And I wish I could say that every mother that needs a lactation consultant can get to one here in the province, but that's not the case at this time. When we asked healthcare providers, what were some of the barriers even in hospital, this was looking specifically at neonatal intensive cares, and I was part of a Bill and Melinda Gates project in Brazil where we incorporated this neo baby friendly, our most vulnerable babies. But it's the infrastructure. Were parents allowed unlimited access, 24-hour presence? Were there protocols written out that were clearly designed for all the healthcare providers working on? They identified a lack of education and a lack of interdisciplinary communication as key issues as well, not to mention the cultural and socioeconomic issues. And if you add the multiple stigma potentials of our neonatal abstinence syndrome babies, of our indigenous populations, that can be an issue. So overall, there were barriers identified regarding how the Baby-Friendly Hospital Initiative was working or not in the NICU. They definitely found people valued lactation and supporting new parents who made that decision. They valued family-centered care. They were using education and champions. Those were all things at sites where it was working, including interprofessional, but barriers as health professionals where they were concerned over the infant's health and letting go of the trust of mothers. They couldn't see how much milk the baby was getting, perhaps, and had issues as well. So I'm going to switch from that very technical global health promotion strategy to a concrete component. We know for mammals, breastfeeding is the biological norm for infant feeding, but it exists within a social construct, and we cannot deny that component. So its rates and practices are determined by the same social determinants that shape our health inequalities and inequities. And remember, it's women who are breastfeeding, so that puts the unequal component up front. So I have a quiz for you quickly. You didn't know you were going to get a quiz when you came, did you? Anybody going to the Perinatal Society Healthy Mother, Healthy Babies in 2 weeks? Oh, I shouldn't be saying this recording. So you'll get your poster questions right is all I'm saying. So for number one, when we talk about best practices around respectful care during infant feeding, suboptimal breastfeeding rates disproportionately impact priority populations. So the new terminology for our marginalized, vulnerable population is key or priority, so I'm integrating that. Mirroring existing socio-demographic inequities. How many say that's a true statement? Okay, we have about 6 hands in the room. How many think it's false? Oh, some people are just not guessing. It's true. You're correct. Now, how about that second one? Unfortunately, a breastfeeding paradox exists where infants of low-income families who would most gain from the health benefits are least likely to breastfeed. Two-part question. This is because those families are less motivated to breastfeed. True or false? How many say true? How many say false? Okay, a little bit more falses. Actually, it is false because of the second sentence. Yes, they would gain most from the health benefits, but the study in 2018 by Orr and al. Demonstrated that food insecure families actually initiate at the same rate as non-food secure families when it comes to breastfeeding. For my population in the United States, and I spent over 30 years working with the Women, Infant, and Children group, 50% of our mothers wanted to breastfeed when we actually surveyed broadly, and we were providing free formula because we just assumed they couldn't do it, and formula was the answer. So we shouldn't assume. What determines breastfeeding success? Again, I'm going kind of quickly through these things, but we do have evidence that shows self-efficacy or a woman's confidence in her own ability to produce milk and to be successful affects whether they meet their infant feeding goals or not. Trauma and violence, huge components. Obesity, I have arguments about that. It's there only because there can be some issues with secondary lactation and how that all works. Smoking, substance use, all can show issues. Our key and priority, so our marginalized populations definitely have a more complex relationship when it comes to looking at initiation, duration rates, and that type of thing. Notice breastfeeding sitting at the top of that little flower there. I could have had them zooming in individually. But that material and social resources at the bottom, so what we identify as social determinants of health, really make the difference. And building on women's confidence, when we look at our trauma and violence-informed population, they perceive themselves to be unworthy. They already have a stigmatized relationship with healthcare providers, and assumptions are made about the likelihood of them breastfeeding safely or not. So building the confidence, making sure that they have access to help, and it does take time to work with new mothers around infant feeding, and you have to have healthcare providers and a population that has knowledge about it. What is normal infant behavior, what is not? This fits very well, and Tina, I'm shouting out to you. I'm pretty sure you're online with us today, to my colleague Tina Revi, who is a public health nurse on Vancouver Island, and she's developed, using the social ecological theory, this component with breastfeeding, where again that parent and baby dyad sits in the center, surrounded by friends, families, and partners. We know how important they are to the success of infant feeding, and they live in a neighborhood, in a community where very different assumptions about infant feeding are made. So when we talk about some of the implications of present societal pressures, I didn't incorporate, Sayanthi completed her master's this year and looked at mothers' use of cell phones related to breastfeeding. And there is huge societal pressure through social media. The breastfeeding apps developed there, I put politely, by non-lactation experts, and mostly by formula companies, and they are meant to make mothers OCD about when they last fed, if they fed enough, if the baby's waking too much, and all these other factors. I mentioned the billions of dollars on advertising, but really there are complex cultural and family dynamics related to infant feeding. I was the first one in my generation. I assume my grandmother had breastfed because they didn't have formula when my mother was born in the 1930s, but I was the first generation of breastfeeding women in my family on both sides. All the mothers had bottle fed and had been told it was fine, and I remember mother and mother-in-law in my bed tapping my leg saying, it's okay if this doesn't work, you know, don't put pressure on yourself, formula's fine. And I do think that today we as healthcare providers have a fear of pressuring new parents. They're exhausted, they're stressed, everybody's telling them something different. We're worried about that. I hesitated with that last line that we don't support skin-to-skin, because here in BC we have a brand new program rolling out, and we are supporting, after the baby is born, to do as much skin-to-skin as possible. We found that increases all sorts of wonderful things. I mentioned the supportive sleeping just because of all the work on back to sleep and what I see new mothers doing in mummifying their babies to sleep so they don't startle themselves. And we still do have a lot of lack of knowledge around infant cues. What is normal for an infant? I love this photo. I could spend time on that too, but I mentioned lactation is a female mammal component. And the story of this woman, I'm happy to send you the link with the photo and the article. Like, she had been 6 years in training for this like 106-mile race or whatever, and got kicked out and not had saved a line because she was pregnant the first time she came up. It's a lottery kind of thing. So she was not going to give this opportunity up, but she was nursing. So you see the guys hanging out and fast asleep, getting their rest in on a break, and she's pumping so there's milk for the next time and nursing simultaneously. As far as tying together now your health promotion, your global concepts, a women's issue, what, if we were to take a person-centered public health approach, might that look like? One-on-one, each person is unique. We cannot predict the experiences they have had. And when it comes to trauma and violence-informed care, this is huge. Breastfeeding, birth, pregnancy, it can all be a trigger for women, and I think we have to approach it very carefully. And sometimes breastfeeding can be the most healing component for women who have been victims of trauma. Success needs to be attainable, flexible, practical, and parent-led. We need to let our folks identify their infant feeding goals, knowing that they will change or not. For me, I thought 6 weeks. I'd be bored to death and need to be back at work, and because that was the American culture thing too. And 6 weeks was my goal. I went a little bit beyond that. And remember what normal feeding is. Keep messaging that consistently to new parents. The enabling environment is including mothers' voices at a policy level, advocating for more increased focus on diversity and duration, not just exclusivity. When mothers head back to work or whatever, they can nurse morning and night and pump during other times. What resources are necessary, and the number one resource in my mind, back to my doctoral dissertation on breastfeeding self-efficacy, is that 2-week period of professional unavailability when the mother leaves the hospital before she has another visit scheduled. Usually 2 weeks is when the pediatrician wants to see them again, and the pediatrician, some have gotten smart and have lactation consultants in the office. Most do not have that as luxury. They don't have a lot of answers for infant feeding issues. To support our baby-friendly initiatives, and we have those going provincially in those birthing facilities, and to link with other issues and causes related to research related to women's health and women's equity issues and rights. From that earlier Perez-Escamilla survey or information I shared, please Google him and look at his aided framework of scaling up a public health promotion policy like breastfeeding. But basically, the summary of that work in those studies are what we need for new parents. Now, in Canada, we have parental leave. Theoretically, if you live in Vancouver, can you afford to live on the decreased salary that you might get for up to 6 months for parental leave? And is that with insurance or not? I mean, there are lots of intricacies related. If you are a faculty member and worried about the tenure clock, are you back in 2 or 6 months because you've got research that needs attention and articles that need to be written? So again, parental leave is a theoretical component. Globally, how do we beef that up so it truly is providing all mothers and parents with support? Reinforcement of the WHO code, education of administrators and health professionals, but improving our curriculum, and that's where I will be headed next. Implementing the baby-friendly initiative steps, and I think we're doing a really good job of that here, and supporting the community-level infrastructure. That's where I see the biggest hole globally. I've just shared in retirement parties for 3 or 4 colleagues who have been my mentors since I came. The women are in their 70s, guys. We got to let them retire, but there's no one replacing them in major community areas where they were the go-to lactation consultant for providers as well as patients. We are making progress. I don't want it to feel all doom and gloom. It's really excited, and even in the 9 years that I've been here, I've seen such great growth, and these are just 2 examples of how we're doing that. The Public Health Agency of Canada certainly is recommitting to this. I think our Prime Minister and his wife are very supportive of this as well, so we're seeing some national components. The Registered Nurse Organization in Ontario did amazing work with really high, Sonia Semenik, who you saw earlier, level folks coming together, creating guidelines that we can use nationally. And here in BC, we have our fabulous Baby's Best Chance Parents Handbook that was just re-updated to include all that. Not just lactation, but infant feeding related to formula use as well. I told you I'd be going a little bit more quickly through these. The breastfeeding wellness teachings, I love this poster. Can you read it? wellness. I've got the caught. Sorry. I think we've talked about the majority of these, that breast milk is the first traditional food. It is empowering for new mothers, and I don't think we focus on that enough. And that learning to parent is a team effort. So that's where I get back to partners, grandmothers, family members, community. We have to listen to what it is the mothers are actually asking. The most significant example I can give of this is a teenage mother who was worried about breastfeeding hurting. She thought she had to poke a needle in her nipple to open the holes for the milk to come out. So we just need to get the questions clear. No Mother and Baby Left Behind, that includes our diverse populations, and excellence. Breastfeeding keeps both mother and baby strong, has many health benefits, and supporting mothers with practical support. Dishes, casseroles, cleaning the house, I think are helpful. Globally, we can disseminate comprehensive and locally appropriate information. We can improve counseling, and I think I'm advocating that that's a key barrier for us, and have culturally important appropriate information, dispelling the myths, especially related to milk supply and how much a newborn needs to eat. I'm going to jump quickly into the therapeutic communication piece because I told you that this would be about talking with new parents about lactation or infant feeding goals. This is my other branch of research. So I've worked heavily clinically on the lactation and policy development side of things, but I am a nursing educator, and my passion lies in working with not just students but practitioners around translating knowledge within practice. The 17 years it takes for it to get there is too long for me to wait. So part of my other frame is simulation. I work with robotic mannequins in different ways. Up until 3 years ago, there was nothing for lactation. There is now. So with simulation, I have integrated a framework, which I'm just going to put up for you quickly, that incorporates what health professionals need is to think critically, intervene therapeutically, and communicate effectively. The communicating effectively is what I've spent the last 10 years on, and the construct I've built includes trust building, empathy, and power sharing. So this is the larger framework. Happy to share that component with you overall, but it's just the communicate effectively I'm focusing on for right now. So we created a global interprofessional therapeutic communication scale. Basically, there are 6 key areas: how you set the stage working with the patient, how you build trust, are you using active communication, what other communication skills, is it patient-centered, and are there any potential barriers? I have left copies of these QR codes up in the back, or a copy you could scan if you want that on your way out. And the 28 item itself is on my ResearchGate site, so you can search it there as well. But I want you to put yourself in this situation, whether you are a healthcare provider or a friend, family member, someone you know is going to have a baby and is either in process of infant feeding, is thinking about breastfeeding. Consider that interaction with them. Take a minute to think about all the details for you. How has your day been going? What are your personal attitudes about infant feeding? Do you have your own children and your own experience? And think about how you set the stage and introduce yourself with them. What's the balance of verbal and nonverbal interaction? And how much information are you gathering about their actual goals, questions, and how might that be impacted depending on where they come from? This is a snapshot of the 3 areas and just examples of some of the questions you would be considering. So in your behavior, did you use a professional greeting? Did you demonstrate appropriate proximity? That's space from them given cultural boundaries and that type of thing. Building trust, did you demonstrate knowledge about who they were and what was happening and ask appropriate questions to get that? What were your active communication skills? And a lot of us think This is health assessment 101. This is how I interview and how I do things. But I think when you sit down and actually evaluate yourself on how well you do some of these behaviors in an interaction, you could be surprised with what comes up. There are very specific communication skills, and we can't forget the nonverbals. And when I observe people in interactions, those can be key, and you know your patients are picking up on them. And whether it's patient-centered or not, are you actually gathering information to do shared decision-making, and I would even say patient autonomous decision-making? Are they getting all the information they need to make up their own mind? The barriers are when you actually give advice rather than suggestions and options, or false reassurance, oh, it's all going to be okay, or infer falsely. So make an assumption like, this woman uses heroin, she should not be breastfeeding. Might be valid, but still find out methods of support. There are basic descriptors that are used, never, always, rarely, and we just would get a little idea on the bottom. Actually, with testing this at 7 schools of nursing across the province with nursing students in simulated and clinical environments, we did find that our analog scale from therapeutic to non-therapeutic was pretty close to the overall measurement. So if I had any web app developers out there, this is on Qualtrics and it's phone friendly and you can download at the end, but I would love to make this a web app that clinical faculty could use or students could use right after an interaction and kind of grade themselves and move on. So in addition to this communication tool, which is used to assess and evaluate the interaction, there are reasons that we should use some more experiential learning when we're teaching our healthcare providers about lactation. I think I've helped you see infant feeding is critically important. Healthcare providers often lack confidence around their ability to support parents, and there are no best practice standards for lactation curriculum. We're getting the revision to that scoping review out tomorrow. When we look at lactation education and what mothers' most reported difficulties with breastfeeding are, breast pain, nipple trauma, and breast engorgement are key areas, and they're also predictors of early weaning. So educating health professionals for lactation, only 4 studies demonstrated that how we are presently doing it is making a difference in knowledge, attitude, and self-efficacy. And clinical simulation was demonstrated to increase students' knowledge and self-confidence. If you think again about that social context of lactation, it does require students thinking about their previous experience and their own attitude toward breastfeeding. When you use simulation and create scenarios and environments for students and practitioners to learn in, you want to base it on evidence-based guidelines. So introducing those guidelines and implementing them is very important, and it allows us then to see, is there actual transfer from knowledge and learning to behavior change and clinical practice? It enhances that synergy between classroom and clinical. We have a whole set of standards that help us to make sure the design is well done. You always need an objective. You want to set it up so it's as realistic as possible and the student or practitioner feels like they're with the actual patient. You want to make sure they have some pre-knowledge about how things are going to work and move. And then you want to do a debriefing at the end and see what they learned from the situation. So we have set up a clinical simulation. We'll be running it in a week with all the undergraduate nursing students, but I'm doing a pilot project that I'll be looking for volunteers in a month or 2, basically focusing on latch, feeding amounts, newborn behavior. There are some assessments that they could make, but I wanted to show you the different models we're using. This first one is a cloth model of a breast that has been handmade by a little woman in a small village in Brazil that I had brought to me by one of my postdocs. And that crazy looking thing is alveoli that actually zips up and comes together, but it gives students a concrete idea of what's going on inside the breast. The moderate fidelity component involves incorporating that cloth puppet doll. So it is a puppet, again, handmade by this woman in Brazil, and you can use the breast to show students how to breastfeed. Now, danger alert, these are exposed pictures here. Think about Robin Williams and Mrs. Doubtfire. Do we have a picture? Is there anyone that doesn't know about Robin Williams and Mrs. Doubtfire? We can actually put on a silicone breast, and it ties in the back. I debated whether to bring them today or not. You can come visit me in my office if you want to see them. We use Lactessa, who I used in the 1990s for my dissertation research. She has an open mind, cloth infant that weighs about what a real infant weighs, and we use these breasts. Now you're seeing some advanced models here, so there are masses and engorgement and mastitis and breast reduction and all sorts of things. There's a basic model that can be used to teach students about lactation. There are some issues about integrating this simulation pedagogy into education, controversy around whether we should use high, so does everybody have to be exposed to the simulated patient who is behind that breast? Can they do just the same learning with the basic model, or the way we always did it was with a little cloth breast and a plastic infant? And describing and defining how that learning is actually translated over. Do we see differences in clinical, basically, is where we want to go with it. So I'm not even sure. I think, 2 minutes. Just to try to pull all this together, lactation is health promotion with global health implications. Respectful care during infant feeding, considering and during, is a right of every parent. Societal pressures related to infant feeding definitely affect parents' experiences. And healthcare practitioners and others can support new parents in reaching their infant feeding goals. My bias is that applying this experiential learning for pre-licensure health professional students and practitioners in this area of lactation education and support has potential for future enhanced outcomes. And if you're interested, I have a Teaching Learning Enhancement Fund. We have created an anatomical foundational knowledge. I was going to post the link here, and my research assistant reminded me we're just submitting the BREBs on it, but people can go to it and learn very basics about infant feeding, and then we'll ask you to do a survey. But this open educational resource we're meeting tomorrow to form 4 scenarios. And then in the fall, midwifery, medicine, physio, and nursing are on board right now, but I'm open to anyone else who wants to play. We'll be piloting with the high fidelity mannequins that you saw here with interprofessional simulations. Also, those who might know Dr. Saraswati Vidam in the School of Midwifery here. She has an amazing project on respectful care during pregnancy and pregnancy care. We're taking a little tiny bit of her survey and using it for infant feeding, piloting. That's why I asked about Healthy Mother, Healthy Baby. That survey will launch in 2 weeks, and then it will become part of SARAS's national survey. It has been very well examined for respectful care to get at the demographics that will help us identify key and marginalized populations. And hopefully we'll be able to evaluate the translation of that learning, the simulations, into clinical practice. Hopefully the students that come as part of the pilot project will give us feedback. So before you leave, just consider when you walked in the door, how when you walk out you might be a little bit different. How might you engage with someone exploring health promotion needs related to lactation and infant feeding? How can you support new parents to overcome some of the barriers that we discussed, especially when they're exacerbated by stigma and consequential mistrust? And what would a strengths-based approach to health promotion for lactation look like? I think I'm at time. I believe we met the objectives I set out to, and I just want to make sure I recognize all the amazing people who have been part of my journey. Yep. Oh, I wasn't sure if you needed this mic or that mic, so you're fine.
Theoretically, this turns on.
Yes.
So thank you very much for that talk. I will share, the poking the pin, which was really difficult to hear, right? But I do remember my own anecdotal for me was I was surprised that it wasn't just one. It's not a garden hose, just for those of you that haven't. It kind of sprays in many different directions, and that kind of confused me. And my son, I would say, at the beginning. But I think there's, the reason I bring that up is there is a lack of just knowledge about it in general, and I'm not really sure why there should be about breastfeeding.
Well, and I thought of beginning with, how many have met their goals or, didn't meet their goals, because I find, especially with physicians and nurses, that healthcare providers assume they learned it all in school. You don't need any help from me. And perfect examples of how it's individual for all of us.
Yes, I don't think that there's a lot of women's health education in a number of programs, unfortunately. Are there any questions?
Not a question, but just in relation to that, I mean, people who live in extended families have all people get that. Actually, it's a long time ago, and that's not been the case for several generations. And so each woman is learning it on their own individually at the hospital initially and outside. And let's say someone's involved with it is sort of radical, but involved with that. And you have to learn how to do it. You need support for that.
So the comment, if we're recording and so people can hear, is that previously people would see breastfeeding being done, and really 3 generations. Oh, you had a mic on. Okay.
I should have put it on.
Oh, so we'll know for next time, and others will know. But that is a huge point, and that's why I credited La Leche League in the beginning, because that was my village, and I went, and there was a room full of women sitting around breastfeeding and showing me how to hold a colicky baby in a tummy hold, and just, I think I was there 4 days after the birth. I was just panicked. And that's where I wanted to talk a little bit about Brazil, because there's huge social marketing components, and in Brazil, seeing someone breastfeed is like seeing a handshake here. It's really the buttocks that are more sexualized there. Oh, good, we have an online question as well. Great comment, though, and great theory, and as the first one in my generation, I had no one in the family to look to.
Yeah, I was extremely lucky at a midwife second, but my mom was a big proponent of breastfeeding, but which she taught me, which I can see if you're trying to learn by yourself or even in a hospital, one of the biggest things is stress. Really, if you're stressed out, there's no letdown going to happen. I noticed in your list a lot of those things I would categorize as stress. And grad students would be phoning me or get a manuscript rejected, but as soon as you sort of try and reduce that stress, the letdown can happen. Anyway, I can imagine that's a very tough thing to learn when you're just trying to learn it, especially in a somewhat sterile environment. So, question. Thank you for the awesome talk, comment rather than a question. I'm a huge breastfeeding champion, yet there has been some pushback about how baby-friendly initiatives in hospitals are not always mother-friendly. What are your thoughts?
And I'm really glad that our participant online brought that up. That's where I had the one note about healthcare providers are fearful of pressuring new mothers related to infant feeding, and I think it does go back to the respectful care component of finding out what does the family see as their own goal, what are they hoping to do. My experience is that the majority really, really, really want to breastfeed, and this is the piece I did not say. When they are not successful, do not meet their infant feeding goals, the layer of shame and guilt, and that's where as society we have to be careful too. I have women telling me, I pump my milk, it's in a bottle, but if I'm giving my baby a bottle, I'm getting the stink eye because I'm not breastfeeding. So I think we have to be really careful, the realities we set up for women. And Lisa, you know, the idea about the stress, the hormonal, the lack of sleep, that's where I keep going back to the support new parents. We do not have support in our society right now. And because of the mobility and the other pressures, which are enormous, hundreds-fold.
Yeah. I mean, I was midwives, I don't know if this is still true in BC, but they come to your house. So I didn't have to, baby number 1, hospital, baby number 2, at home, but with a midwife. And the next day, the midwife came to make sure the latching was fine. And that was just just a godsend, because you do not want to be traveling around with a new baby because you're not. So I don't know if the same thing happens. And there were more.
Do we have any midwives in the room? I have a sense there's some online.
Yeah.
But Julie just came from Brazil, so yeah.
But I think like back in Brazil, we do have mostly on the public. Well, back in Brazil, mostly on the private actually section. Now there are a lot of services that are offering the midwives to come into the house and also help like with the breastfeeding, like the lactation consultancy. On the public system, in theory, according to our law, we should be going to their houses on the first week and also help with the breastfeeding. But we have we do lack a lot of nurses, so often we really miss like this deadline, and when we do have the chance to come to their houses and do the visiting, we already missed like they had a lot of issues with breastfeeding and lost opportunities. So it's really unfortunate that we don't have the resources, the human resources to help with that.
I do believe that our midwives in the province, that is part of the package, if you want to say, and often that they will come out. And Sayanthi, anything different on BC Women's? There's a lactation clinic there, and I know our public health nurses often can go out as well.
I think we usually do, well, not us, but the community health nurses will do a visit, especially if there's any feeding concerns. But again, I always usually tell my patients to really advocate for that, because usually they get the phone call first and then follow up if they need. But we do have a lactation consultant clinic, and I do think midwives still do like the 24-hour visit. Yeah.
Thank you.
I love that, because I like to sleep. So it was really good. Any other questions? The other thing, if there's no other questions, I just wanted to, you've probably seen it. Have you seen that movie? I think it's a documentary, sorry, I shouldn't say call it movie, called Milk? I think it's just
We
called Milk.
showed it here as part of a partnership with BCLCA,
It's really fantastic. I think it might be on Netflix. But
there's another new documentary as well that might be on Amazon Prime that I just found out about that is actually dealing with what you asked about, the pressure.
Right.
And dealing with mothers' perceptions that are not positive or reflecting well. And again, there's an undermining of the formula company there. You know, it's not the ideal, it's not what we want, but we really do need the human resources, and we need everybody to be providing the same message.
Yeah, it's just interesting thinking about all the different talks we've been having, and the common theme I think that keeps coming up is we don't have enough information out there on periods. Periods don't need to be painful, what menopause really is, what the symptoms are, breastfeeding, the importance of it.
But Lisa, with the breastfeeding and pain, there's a researcher in UK who I have quoted in a few of the references here, who said, and Sayanthi, it came out in yours too, that mothers felt lied to, that breastfeeding was easy and natural and blissful. And I mean, I think we do have to say for some women there can be issues related to pain early on. They need assistance with latch, the hormone component. I mean, putting on a funny show, having a friend on the phone and a cup of tea to relax you can sometimes be enough, because it's very physiological.
I think I also got lucky because I had a midwife friend who gave me a book, and I can't remember what it's called, but I just when you said, you know,
Laughing.
oh, it's blissful. The third or fourth chapter was called something about like the blissful months, which are like it was 2 to 6 months, I think, were the blissful months. So it takes a while to get to the bliss.
Right.
Sleeping like a baby. I was always like that. They don't sleep that much in a row.
Exactly.
All right. Well, if there are
Thank you
any
so
other
much
questions,
for your attention, and
so
I do
much.
have these.
Thank you.
I might just spend a minute so they're recorded unless we've turned the recording off. Thank you all for coming out as the snow started and other things are happening. It was great to have you here.
Thank you.